Topic number 13: Purulent diseases of the skin and subcutaneous tissue. Lecturer Shevchenko Alexander, Baltic Federal University Medical Institute, Kaliningrad, 2020. This is anatomy of the skin. You must remember that we have epidermis and dermis, which lie on the subcutaneous tissue. We have hair follicles, sebaceous glands or oil glands in the tissue. In all cases of inflammation, there are specific signs. The patients feel ill. The degree depending upon the size of the pathological process, the virulence of the organism, and tension within the cavity. The temperature is elevated. In severe cases, rigors may occur. 5 classical local signs of inflammation are heat, redness, tenderness, swelling, and loss of function. And, of course, pain. Purulent infection penetrates through small injuries to the skin, so-called minor traumatism. In such cases, a purulent process most frequently develops because the patients at the first fail to pay proper attention to their affection and are not given timely and required aid. If aid is administered in due time, the wound is painted with iodine tincture and a sterile dressing is applied. The wound is protected against contamination. Purulent diseases develop only in exceptional cases. Failure to observe the rules of personal hygiene, dirty bodies, scratches, etc. is favors develops of purulent infection. Penetration of bacteria deep into the tissue does not always result in development of a purulent inflammatory process. A pathological process may develop or fail to develop depending on the inborn and acquired properties of the body. Age, sex, nutrition, mental state, etc., which determine its interrelations with the pathogenic factor. In some cases, under the influence of purulent infection, only a local reaction in the form of an inflammation of the tissues at the point of entrance of pathogenic bacteria develops. But usually the process does not end there, and a general reaction manifested in rather marked disturbances throughout the body develops. The clinical picture of the disease develops according to the virulence of the microbes, which have gained entrance into the body and the state of the natural defensive powers of the latter. Boil or furuncles. Boil constitute one of the very widespread purulent diseases of the hair follicle and sebaceous gland. The disease begins with an appearance of a painful infiltrate in the skin in the form of an inflammatory node differing in size from a pea to a pigeon egg. The skin grows red over the swelling and local pyrexia is observed in the region of the focus. The disease develops over a period of 4 to 6 days, and a purulent blister, exfoliation of the epidermis by pus, is formed at the most protruding part of the swelling. A focus consisting of a necrotic gland with surrounding subcutaneous tissue is found under this blister. The subcutaneous tissue is subsequently discharged together with the pus, the core of the boil. The remaining small cavity fills with granulations and heals. Complications. A boil may lead to cellulitis, particularly in those whose power of immunity is less. Boils also may lead to infection of the neighboring hair follicles, where numbers of follicles are too many, leading to hidradenitis or to the carbuncle. Boils usually secondary infect the regional lymph nodes. Treatment. First, the general health of the patient has to be improved, as boils often occur in the individuals with debility and ill health. Second, incision is usually unnecessary as the pustule is very small. Only a touch of iodine of the skin pustule will hasten necrosis of the overlying skin and help the pus to drain out. 3. If escape of pus does not occur spontaneously or with application of iodine, removal of the affected air allows ready escape of pus. Antibiotic is usually not required. It is possible when multiple boils appear or if boils reoccur. After escape of pus, this place should be cleaned twice with a suitable disinfectant. Example Gradia bethadine or hexachlorophene. This discourages development of further boils. If boils are recurrent, diabetes should be excluded. Carbuncles. After penetration of pyogenic bacteria under the skin through hair follicles and sebaceous glands, the process spreads in depth if the conditions are unfavorable to the body and affect considerable section of subcutaneous tissue. It is an infective gangrene of the subcutaneous tissue due to staphylococcal aureus infection. Gram-negative bacilli and streptococci may be found coincidentally. There are a book by Sir Arthur Conan Doyle, Bull Carbuncle, in the cycle about the Sherlock Holmes. Somebody think about this diamond looks like carbuncle. Side carbuncles are mostly seen on the back, in the nape of the neck, where the skin is coarse and vitality of the tissues is less, the shoulders, the cheek, dorsum of the hand, and the other rare sites. Hirsute portions of the chest and abdomen may also be involved. Pathogenesis. When the invading staphylococci penetrate the deeper layers of the skin and the subcutaneous fat, a carbuncle is formed. This consists of a series of communicating abscesses, which discharge by separate openings on the surface. That is why the surface is sieve-like. Individual compartments in the carbuncle are maintained through persistent fascial attachment to the skin. Carbuncles may be more extensive than they appear. There is a central large swath surrounded by a rosette or small areas of necrosis. In untreated cases, the infection may extend with fresh openings appear on the surface, which coalesce with those previously formed. Under treatment, when the central swath is drained off, fibroblastic reaction starts from the surrounding granulation tissue, and carbuncle heals with characteristic indurations. Clinical features. It generally affects males above 40 years of age. Often the subject is diabetic. It commences as painful and stiff swelling which spreads very rapidly with marked indurations. The overlying skin becomes red, dusky, and edematous. Subsequently, the central part softens and a multiple of vesicles appear on the skin. Later, these vesicles transform into pustules. These pustules subsequently burst, allowing the discharge to come out through several openings in the skin, producing a sieve-like of cribriform appearance. These openings enlarge and ultimately coalesce to produce an ulcer. At low floor of the ulcer lies the ashy gray swath. Finally, the swath separates, leaving an excavated granulated fascia, which heals by itself. When the resistance of the individual is poor in diabetic subject, the swathing process may extend deeply into the muscle or even bone. Constitutional symptoms and toxemia vary according to the degree of the resistance of the individual and to result of the treatment. In case of carbuncle, operation is required. A. When toxemia and pain persist even after a course of antibiotics, and B. When the carbuncle is more than 2 inches in diameter. It must be remembered that incision is never made unless there is softening in the center. Technique. A large circular incision is made extending up to the margin of the inflammatory zone. Swaths should be cleared with a piece of gauze. Apices of the 4 skin flaps are generously excised. The wound is covered by a gauze dressing. The part should be kept in the perfect rest for a week and antibiotic is continued till resolution. Hidradenitis is any disease in which the histologic abnormality is primarily an inflammatory infiltrate around the green glands. Usually appears in the armpit or groin, but can be on the face or abdomen. Affected groin on the picture, and here we have affected armpit. On the picture we see scars. Phlegmon or cellulitis. In English, most common use the words of cellulitis, in Russian phlegmona. Phlegmon is a medical condition where there is acute diffuse inflammation of the adipose tissue, which spreads with formation of purulent exudate. Symptoms of inflammation from phlegmon consist of localized pain, hyperemia of skin redness, increased local temperature, painful tissue swelling which can be non-clear, bordered or clear or bordered. It can be tumor, decreased function of the affected body part. Treatment. Conservative treatment consisting of antibiotics is started if the phlegmon is mild and inflammation is persist without any signs of infiltrates. In severe cases, surgery is needed to drain the phlegmon, to excise dead tissues, and to prevent further spread of infection. Surgery is done under general anesthesia, where the cavity which contains the phlegmonous process is cleaned with antibiotic and antiseptic solutions and the dead tissue is removed. Abscess. An abscess is a collection of pus. The suppurative infection gradually leads to cell death and liquefaction. The toxin of pyogenic organisms kill both tissue cells and those of the exudates. Liquefaction of the head tissue is caused by proteolytic enzymes released from the dead polymorphonuclear leukocytes. The resulting yellow alkaline fluid is called pus. It contains both disintegrated and living leukocytes and living dead bacteria. An abscess is a cavity filled with pus and lined by a pyogenic membrane. This pyogenic membrane consists of dead tissue cells and a wall of granulation tissue consisting of for the most part of phagocytic histocytes. As the recovery starts, this pyogenic membrane is covered into fibrous tissue and the cavity is gradually covered with granulation tissue, which transforms into collagen fibers. Clinical feature. Cardinal features of acute inflammation are usually present. So we have pain, redness, swelling, dysfunction, and elevated temperature. Fluctuation is a symptom of the presence of fluid in a closed cavity of the body, accessible to palpation, felt during touch. Fluctuations in the liquid collected in the cavity. As you see on this picture, by one hand we touch and push slightly the contents of the abscess cavity, and we must feel by the other hand that contents of the abscess is like touching our hand. And if we feel the wave, it's a positive sign of fluctuation. If we didn't feel the wave that touched our another hand, that this is not an abscess. Special investigations. A conventional radiology is only successful when there is air or gas with pus. This examination then reviews fluid levels. Example: gratia subphrenic abscess, lung abscess, etc. Sometimes presence of pulses suggested by opacity. Example: gratia nasal atrium, pleural cavity. B. Isotope scanning is helpful in locating collection of pus or site of infection by accumulation of radioactive technique after its intravenous injection. Thus is mostly used as a diagnostic tool in demonstrating brain abscesses, hepatic abscess, and osteomyelitis. Similarly, radioactive gallium scan is sometimes used to detect pelvic, periphrenic, mediastinal, or suprarenal abscesses. Ultrasound have considerable value in the differential diagnosis of abscesses and cellulitis, and CT scan. I want to say another one method to diagnose the abscess. If we talk about subcutaneous tissue and skin, we can take the syringe and make puncture and aspirate the contents of the probable abscess, and if we have purulent contents, we must provide surgery because it is abscesses. So treatment. In the initial stage, when the pus is not localized, conservative treatment may be advised. The affected part is elevated and given rest. A suitable antibiotic therapy should be started. Second, when the pus had been localized, it should be drained. The old adage holds true today also: where there is pus, let it out. So the basic principle of treatment of all abscess: first, to drain the pus. Second, to send a sample of pus for culture and sensitivity test. And third, to give proper antibiotic. Free or liberal incision. In this technique, a liberal incision is made on the most prominent part of the abscess, so the cause least damage to the surrounding healthy tissues. It should be placed on the most dependent part also, so that gravity will have drainage. Incision must be adequate, liberal for easy drainage of pus and to avoid chronic. If any important structure like nerve or vessel is liable to be present in the depth, the incision should be made parallel to these structures. This incision should be bored through the skin, subcutaneous tissue, and deep fascia. The muscle should be incised along the line of the fibers. Or we can use the Hilfen method. This method is chosen where there are plenty of important structures like nerves and vessels around the abscess cavity, which are liable to be injured. This is particularly employed in places like neck, axilla, or groin. In this technique, the skin and subcutaneous tissue are incised on the most prominent and the most dependent part of the abscess cavity. A pair of artery forceps or sinus forceps is forced through the deep fascia into the abscess cavity. The blades are gradually opened and the pus is seen to be extruded out. The forceps is now taken out with the jaws open to increase the opening in the deep fascia. A finger is introduced to explore the abscess cavity. Exploration. After the incision of the abscess cavity was executed and some amount of pus has been extruded, a finger is inserted into the abscess cavity and all the walls of the abscess are broken. There must not be any walls unbroken at this, as this will lead to chronicity. All walls are broken into one cavity for complete drainage. Contra-incision. When the most prominent part is not the most dependent part, complete drainage of pus is not possible with a single incision, so a contra-incision is required at the most dependent part to facilitate drainage by gravity. In this technique, through the first made incision on the most prominent part, a sinus forceps is passed to the most dependent part. The blades are slightly made apart, and then with a knife a fresh incision is made on the skin between the tips of the sinus forceps. Drain. A corrugated rubber drain is usually used for drainage of abscess cavity. When counter-incision is used, the drain extends from the first incision to the counter-incision. When the surrounding granulation tissue is bleeding too much, roller gauze should be packed inside the wound and it can be kept for 48 hours. Some surgeons believe in local application of antibiotics into the abscess cavity. Some believe, and I didn't believe. You should remember how we call this. First, it's Penrose drainage, and second, it's Jackson-Pratt drainage. By the mechanism of action, which drains do you remember? I give you a few seconds to remember it. So we have passive drainage, where the contents of the wound will be leaking by the force of gravity. Active drain, where we aspirate the contents of the wound. And we have full washing drain, when by the one tube we give isotonic solution or maybe some antiseptic, and by the another tube it flow out. The rest of the affected part is very important postoperative measure. This is expedite healing. Proper antibiotics selected by culture and sensitivity test should be started immediately. After 48 hours, the dressing of the drain should be removed. Fresh dressing is done every day. Sterile gauze. If the cavity has to be packed, the packing should be made gradually lighter to help the cavity to heal. Erysipelas. It is an acute inflammation of the lymphatic of the skin of mucous membrane. The causative organism is usually Streptococcus hemolyticus. The infection may be transmitted from one patient to another through the dressing materials, hands of the medical personnel, instruments, etc. In erysipelas, the disease begins with prodromal phenomena, general indisposition suddenly followed by excessive chills and temperature up to 40 or 41 degrees of Celsius. Vomiting is sometimes observed. Subsequently, the temperature either persists on a high level or from time to time drops. The disease spreads from the site of inoculation, and the advancing margin becomes bright red and slightly raised above the general surface. The margin itself is irregular in outline. Just beyond the sharp margin, the lymphatic are crowded with streptococci. The margin shows acute congestion. The lymph spaces of the corium of the skin are crowded with cells. The inflammatory cells are mainly lymphocytes and wandering mononuclear cells. It should be remembered that whereas in ordinary streptococcal infection, the characteristic defense cells is the polymorphonuclear leukocyte, in erysipelas this cell is small mononuclear cell. The center of the patch shows little change. There is notable absence of pus formation. Following the fading of the inflammation, brown discoloration of the skin may remain. Clinical features. The conditions which predispose this disease are debilitating state and poor health. The condition commences as a raw pink rash which extends to the adjacent skin like a drop of grease spreading on a piece of paper. The vesicles appear sooner or later with rash and rupture. Serous discharge comes out from these vesicles. Fever and other constitutional symptoms may be present with varying degrees. When it affects skin below which there is loose areolar tissues, example gratia, orbit, scrotum, etc., there is considerable swelling of the part due to edema of the subcutaneous tissues and thus very much resembles cellulitis. To distinguish between the true erysipelas and cellulitis, the following points in favor of erysipelas should be borne in mind. The typical rosy rash disappears on pressure and feels stiff. The raised rash of erysipelas has a sharply defined margin, which is better felt than inspected. The vesicles of erysipelas contain serum, in contraindication to the cellulitis in which they contain pus. In case of the face, Millen's ear sign is significant, in which erysipelas can spread into the pinna, a bean cuticular affection, whereas cellulitis cannot spread to the pinna due to close adhesion of skin to the cartilage of the ear, without any areolar tissue. Treatment. The patient must be confined to bed, all pressure and rubbing bandages must be removed, and the tissues around the redness must be painted with iodine to prevent the disease from spreading. Irradiation by an ultraviolet lamp is effective. The wound, which served as the source of infection, must be examined to see if any pus is retained under their edges and if the pus is being well discharged. Daily administration of antibiotics is sulfonylamides. Lymphangitis. A spread of infection along the lymphatic system is manifested in a disease of the lymphatic vessels and lymph nodes. Inflammation of the lymphatic vessels, lymphangitis, is one of the frequent complications of infected wounds, especially during the first weeks following injury and of local purulent diseases. Lymphangitis also develops in cases in which the discharge of pus from the wound is hampered. New infection gains entrance into the wound during dressing and during accelerated outflow of lymph. For example, as a result of untimely or vigorous movements of the affected organ. The local manifestation of lymphangitis is the appearance of longitudinal red lines on the skin along the course of the lymphatic vessels. Inflamed superficial lymphatic vesicles which are palpated as a dense cords and are painful to touch. Simultaneously, the adjacent lymph nodes, regional, for example inguinal or axillary, become swollen and painful. General phenomena in the form of chills and fever up to 40 degrees Celsius are also observed. The treatment of lymphangitis consists primarily in elimination of its cause, incision of the abscess, pockets of the wound, etc., and in giving the affected organ complete rest. Confinements of the patients to bed in lymphangitis of the legs and splint bandages of the disease affected the arm obligatory. The red lines and the region of the swollen lymph nodes are painted with iodine. Hot compresses and precision of antibiotics are recommended. If pus is retained in the region of the wound, an attempt may be made to remove it. The pockets are opened, the crusts are taken off, and absorbent dressings are applied. Under the influence of the foreign measures, the inflammatory phenomena in the lymphatic vessels usually abate. The temperature drops within 2 to 3 days, the redness disappears, and with a week everything returns to normal. In some cases, purulent foci or abscesses form along the course of the lymphatic vessels. These abscesses are at first treated with the hot compresses and then excised. Early surgical treatment of purulent processes incision of abscesses to diminish absorption of pus. Antibacterial treatment is used. Lymphadenitis. In purulent process, the infection spreads through the lymphatic vessels and penetrates into the lymph nodes, where it is retained, as we see in this picture. Paroproctitis. It is purulent inflammation of around rectal cellular tissue. We have subcutaneous, rectal type of the paroproctitis. Pubic type of the abscesses. Clinical features. There exist two forms of disease. Diffuse, phlegmon of the pararectal cellular tissues, and limited. Phlegmon of the pararectal cellular tissue is characterized by the serous pacing, fast distribution, necrosis of the tissue, marked intoxication. It is observed at shotgun wound, decaying cancer of rectum, urinal phlegmons. Limited paraproctitis can proceed in the following forms: hypodermic, ischiorectal, submucous, and pelvic rectal and rectal. Hypodermic abscess usually is around the anus. There are revealed swelling, hyperemia of the skin, difficulties and pain at defecation. Ischiorectal paraproctitis usually proceeds more seriously. High temperature, chill intoxication around the rectum up to the prostate and pelvic cellular tissue. This process spread. At finger examination of the rectum there is observed painful infiltrate. Submucous abscess is usually localized in the submucous layer of the rectum above the anorectal line. At finger examination there is determined painful and swelling in the area of the anus. In the difference from hypodermic process, this pain is less intensive. Pelvic rectal abscesses are rare from form of paraproctitis. Abscesses usually localized above the pelvic bottom. Retrorectal abscesses are formed in the result of infection of lymphatic nodes, which are located behind the rectum. In the beginning there are no symptoms, and then it can move down in the ischiorectal cellular tissue with the development of the phlegmon. Paraproctitis is the most cases are usually finished by formation of fistulas. Treatment. In the stage of infiltration, conservative therapy usually used. Antibiotics, sparing that. At the phlegmon or abscess there is indicated urgent operation. It is frequently used the 2 cm semi-lunar section outside of the external sphincter of the rectum. This section of the abscess is made from the cavity of the rectum during submucous abscesses. There are indicated wide sections with the carving of necrotized tissues and using of hyperbaric oxygenation during anaerobic paraproctitis. There is used fluent bathing with the solution of antiseptics, hydrogen peroxide, dioxidine, proteolytic enzymes, and hip bath with dye solutions of antiseptics in postoperative period. Mastitis is inflammation of lactic gland tissue. There is distinguished lactation mastitis as nursing mothers, mastitis of newborns, and a period of pubescence. Etiology and pathogenesis. Pathogenic microorganisms are often Staphylococcus and Enterobacterius. The ways of infection is chaps of the nipple, intracanalicular at the nursing mothers, hematogenous and lymphogenous at endogenous infection. Promotional factors are stagnation of the milk in the gland, bad care of the gland in the period of nursing. Clinical features distinguish acute and chronic forms. Acute mastitis mostly at the period of lactation appears. Chronic forms are very rare, appear in the result of wrong treatment of the acute one or in the result of specific damage, tuberculosis, syphilis, etc. Acute mastitis can be serous, infiltrative, upsetting, phlegmonous, gangrenous, is divided. It can be said mastitis are the stage of the same process which can turn one into another. Conservative treatment. The kind of treatment depends on the stage of the process. At serous and infiltrative forms there is indicated conservative therapy. Nursing must not be stopped. The milk must be strained off by hand or with milk sucker off. Antibiotic therapy, semi-synthetic penicillins, physiotherapy, ultraviolet, and novocaine electrophoresis. There is also can be used retromammary novocaine blockade with antibiotics. At the abscessing form, it is indicated operative treatment. Sections are made dependent on localization of abscesses at subarachnoid semilunar, at intramammary radial sections, along the lactic ducts, at retromammary arch section under the gland. Surgical treatment. Sick persons with phlegmonous and gangrenous forms of mastitis need, in the urgent operation, several radial sections of 8 to 10 cm, coating of necrotized tissues and draining flowing rouge with antiseptics. Treatment is supplemented by infusion therapy, antibiotics, transfusion of the blood, simulators of immunity, disintoxication, and the most common suppurative information in the ambulatory at the end. Avid low or felon is an infection of the tip of the finger. Symptoms. A felon causes extreme pain at the fingertip, especially when pressure is applied to the fingerprint surface. At the end of the finger swells, is warm and turns red. There may be an accumulation of a white, thick discharge pus. As the felon increases, the fingertip may feel numb, and bending at the finger may be painful. Sometimes you can hear that the patient tries to sleep and he cannot sleep all night. It called in the hospital sleepless night. Diagnosis: a sleepless night sign, if I want to be correct. Diagnosis: your doctor can usually diagnose a felon just by examining it, and treatment: felons are usually treated with minor surgery to allow drainage. So thank you for your attention. I hope you enjoyed this video. I hope you learned something new from this video. Bye bye.